Hi everybody, it's Dr. Sloan. I'm going to do a quick review of cardiovascular medications. These are the medications that are part of cardiovascular part 1. Now we talked about a lot of these drugs and so I'm not going to go over them in a lot of detail. I want you to have enough that you're good for the exam. So we talked about dyslipidemics. That's used for high cholesterol. That's kind of another. Remember, dys is bad, lipid is fat, and emics is blood. So high fat in the blood, and anti-anginal. So meds that work to fix angina. And again, we're going to talk about these in more detail. So our first drug is simvastatin. And remember, we talked about how all statins obviously end in statin. And probably the one that most people know is atorvastatin, which is Lipitor. But the one that's given here in your example is Zocor. And these are HMG-CoA reductase inhibitors. And basically what they do is they inhibit this HMG-CoA reductase, and that is critical to the process of cholesterol synthesis in the liver. So if you don't have this enzyme, then you can't make cholesterol, and that's good. That decreases the amount of cholesterol in the blood. It also increases the high-density lipoproteins, which we want. Remember, highs we want. Highs you want to be high. And decreases the low-density lipoproteins, which you want to be low. These are the ones that are more harmful. And so this is a really great drug given to many, many people. And the hope is that we would prevent the formation of these plaques by decreasing this production of cholesterol in the liver. So side effects of these drugs, probably the really big one that people need to know is that it can cause myopathy, muscle pain, and can progress to rhabdomyolysis, which is really, really serious. And that rhabdomyolysis, the breakdown of all that muscle protein, then causes kidney damage. So something to watch is to really monitor for reports of muscle and joint pain. If there's muscle pain, we want to look at their CPK, that's their creatinine phosphokinase, and see if that is elevated. That might tell us there is some real stuff going on here. We also want to monitor liver function tests. Well, that makes sense, right? Because this drug works in the liver to reduce cholesterol production. So the side effects and the monitoring totally makes sense with the drug. This is a very busy schematic over here. If it's helpful to you, great. If not, don't worry about it. But anyway, it interacts with grapefruit juice and increases protein levels when taking warfarin. That's something that you definitely need to keep track of, because it's possible that somebody could be taking a statin and warfarin at the same time. Nitroglycerin. We talked about nitro in class quite a bit, and I'll just say it's a vasodilator, nitrate, right? It's an anti-anginal, and there's lots of mechanisms of action, but basically it causes vasodilation, and that's great because then it dilates coronary arteries and veins. That decreases oxygen demand needed by the body because the heart doesn't have to pump so hard. And it works really well for angina. Opens up those vessels, gets blood and oxygen in to those tissues. The problem with it is it can cause a significant headache, and because it's a vasodilator, all the side effects are related to vasodilation, right? We're going to have hypotension, maybe rebound tachycardia, heart palpitations, vertigo, which is just dizziness, right? Flushing. And the problem with nitroglycerin is that you develop tolerance with continued use, meaning that the drug, your body gets used to it and the drug gets less and less effective. So can't take nitroglycerin forever for angina. Eventually, either the angina is going to resolve because the patient's in better health, or patient will probably go on to have, an MI. So different dosages, we talked about this. We talked about sublingual, and that the onset's quick, right? And it lasts 30 minutes. And we give those pills. So let's say you have chest pain, take a nitro, wait 5 minutes. Take another one, 5 minutes. Take a third. You're done. If you still have chest pain, we need to get the provider. And then I think I mentioned here transdermal, that you need to be really careful. It comes in patches or in creams, and you need to make sure that you remove the old patch or the old cream before you put on new, so that you're not giving them too much of the medication. So the nursing care, we talked about this. You should call 911. And after this one actually says, if not relieved in 5 minutes, call 911, take a second tablet, and take a third. So after the first one, if it's not relieved, you should call 911. Don't delay. We want to get the patient to medical care right away. Don't touch the ointment during patch application or ointment application, because it will also cause vasodilation in you, and that could be unpleasant. You may give a beta blocker or a calcium channel blocker to suppress the tachycardia that comes as a result of nitroglycerin. And patients can use over-the-counter analgesia for headache, but it should resolve on its own within 20 minutes. And then report dizziness, syncope, which makes sense because remember, it's a vasodilator. So they may drop their blood pressure, they may feel faint, and we definitely want to check their pulse and report tachycardia. So people who shouldn't get nitro are people with allergy, glaucoma, because this medication is going to make glaucoma worse, GI disease, or hypovolemia. Because if they're hypovolemic and we give them a nitrate and drop their blood pressure, it's going to take something that's bad and make it worse. The other thing I would say is you want to be very careful giving this to someone who's on other vasodilators, like a drug for erectile dysfunction. Things like Cialis, those also cause potent vasodilation. And if you give it along with another vasodilator or something that drops blood pressure, you could potentially have a patient who has really significant hypotension, possibly irreversible, which could cause death. Antihypertensives, we're going to talk about these. We have ACE inhibitors, beta blockers. So our ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2 in the RAS system, and they cause an increase in plasma renin activity and a reduction in aldosterone. Remember, aldosterone has to do with salt and water, and so if you have less aldosterone, you can have less salt, less water, lower blood pressure. So these are used to treat mild to moderate hypertension, congestive heart failure, or acute MI. The ACE inhibitors can cause hypotension, which, if you look at the rest of these, make a lot of sense. Headache, dizziness, nausea, vomiting, diarrhea, I think is just related to the drug in general. Tachycardia, fatigue. They can cause hyperkalemia, so we need to watch that. But probably their biggest side effect right here is this cough due to increased bradykinin. And a lot of times the cough is, annoying but not serious. It doesn't really indicate anything. So we definitely want to keep an eye on that. Patients who continue to have cough, we worry about their compliance with taking the medication. Because they want to avoid that cough, so it's probably better to switch them over to an ARB, which is an angiotensin receptor blocker. So anyway, nursing-wise, we're going to slowly increase the dose. We may stop diuretics temporarily until we see what these medications do to blood pressure, Because if we lower their blood pressure and we offload a bunch of fluid together, we may have somebody who's very hypotensive. We want to avoid high potassium foods because of this hyperkalemia issue. And then report dry cough. Okay. And then people who shouldn't get it are people who are pregnant, already have hypotension, which why would they get it? But maybe they're getting it for another reason. Angioedema, which you guys heard my whole story with that. Liver disease and bone marrow depression or suppression is what it should really say. Somebody whose bone marrow isn't working well shouldn't take this medication. And actually, I don't really know the reason behind that, but anyway. Probably the big thing to remember, though, is the cough for the pills. Okay, so now we're on to the beta blockers, olol. See all the olols? And these bind to beta receptors. You already know this in cardiac tissue, nodal tissue, and we talked about nodal tissue, which is the conduction system. So the heart has both beta 1 and beta 2, although the predominant receptor type is beta 1s. So these receptors primarily bind norepinephrine, and yeah, they work well to treat hypertension, MI, angina, AFib. And so they are going to slow down heart rate in addition to reducing blood pressure. So side effects are, remember, too much of the intended effect. So it could cause bradycardia. It could cause postural hypotension. It could cause CHF. It could cause bronchospasm because of the beta 2 crossover. Now, metoprolol is cardioselective. Atenolol and propranolol are not. And so these will affect beta 1s and beta 2s, whereas metoprolol will affect more just beta 1s. It can cause heart block, and so that's something to be aware of, and a night cough. Oops, sorry. It should be not given to somebody whose heart rate is less than 60. So you're like, okay, Professor Sloan, but what if it's 58? Well, here's the deal. Like, do you really want to risk it? So I would say make sure that they're 60 or above. And if they're below and you really think maybe it's just kind of a weird thing that their heart rate's low, maybe you look on their Epic and see that their heart rate's really been like 70s or 80s, just wait a few minutes and go back and take it and see, and then you can make a decision from there about whether you're going to give it or hold the medication. But if it's below 60, you definitely want to hold it. And if their systolic blood pressure is less than 100, you want to hold it as well. Patients in heart block, ventricular failure, pulmonary edema, or acute asthma, you're not going to give it either. Again, because of that beta 2 crossover, you would worry about this a little bit. And pulmonary edema, if we cause too much vasodilation, we could have some backing up of blood into the lungs. So we want to be careful about that. So you want to look for hypertension, bradycardia, signs of heart failure, hypoglycemia in diabetics, and bronchospasm. You want to teach the patient to take their pulse, to not chew extended release meds, which you guys already know, and taper over 2 weeks if you're going to stop the dose. So beta blockers can't just be stopped right away. Coagulation modifiers, we have 3 different types. We have 2 that are basically anticoagulation drugs, and then we have one that is actually like a clot buster, a thrombolytic, which is alteplase. So aspirin we think of as, oh, you take that for a headache, but it also is a platelet aggregation inhibitor. It binds to platelets. It irreversibly blocks the formation of this, which is a prostaglandin, which decreases platelet aggregation, and it increases coronary blood flow, right? If those platelets are more slippery, they're going to be able to they're not going to stick together, cause a clot, which is going to leave nice clear arteries for coronary artery blood flow. It's usually taken daily. It's indicated for all patients with acute coronary syndrome. So I am not exactly sure what fits into this, but for sure, people who have different arrhythmias are going to probably be taking this. Now, they may take another drug as well, or a different drug. We'll talk about that in a minute. But the dose during MI, so if a patient comes in to the ED and they're like, oh, my chest hurts, they put them on an EKG, they see an ST segment elevation. Remember, we talked about STEMI, ST elevation, MI. They're probably going to give them a couple of chewable aspirin. As long as the patient's awake, they're going to give it to them and say, you know what, go ahead and chew these up. And they're going to literally give aspirin like on the spot to try to help with that. Okay, here's another kind of it's not an anticoagulant, it's an antiplatelet drug, clopidogrel, better known as Plavix. And again, just remember it's an ADP receptor blocker and it inhibits platelet aggregation. This is the most important part right here, that it inhibits platelet aggregation. It just has a slightly different mechanism of action from aspirin. And actually, if you look here on this really nice little picture, it'll sort of tell you the different ways that these medications work. So it affects throughout the lifetime of platelets, which is 7 to 10 days. And it can cause GI upset, abdominal pain, diarrhea, nausea. So mostly GI symptoms. You're going to check for GI bleed or generalized bleeding because remember, this is going to make platelets slippery. They're not going to aggregate well, so people aren't going to clot well. You want to check platelet counts periodically to make sure that that those are okay. And then this is given once daily. And then if they need to have surgery, this has to be discontinued a week before surgery so that the patient doesn't bleed out during the surgical procedure. We talked about ginger, ginkgo, and primrose, which increase the risk for bleeding. So you don't want to take those with this as well. Okay, anticoagulants, heparin and Lovenox. This is low molecular weight heparin, and this is just regular heparin. This is like good old-fashioned heparin, been around for a bajillion years. This is a little bit newer, but again, has been around for many, many years. It's not new in terms of you guys. So this is where it tends to work, is between thrombin and fibrin right here. And if it blocks the formation of fibrin, now you don't have what you need to make a blood clot. Okay, you don't have the mortar. The recipe's not right. So the mechanism of action for heparin is that it's a thrombin inhibitor. Side effects are that it can cause hemorrhage, low platelet counts. These two are the same, thrombocytopenia, low platelet counts. Low platelets, just different way to say it. And then autoimmune reaction. We talked in class about HIT, heparin-induced thrombocytopenia. And that is something that you need to know about. If you see heparin-induced thrombocytopenia, you'll know because the platelet count will drop usually by 50%. So keep an eye. What's their trend been on their platelet count? Now, if a platelet count has not been ordered recently and they're on heparin, that is something that you should advocate for your patient. Hey, my patient's on heparin. I don't see a platelet count in the last few days. We need to get one. And you can remind the physician that you need to do that. Heparin is managed with PTT. It is partial thromboplastin time. And again, I'm going to do a separate little recording for you on the labs for heparin, but you want to look at their baseline CBC, especially the platelet part of that. You want to look at their hematocrit because if they're bleeding somewhere, their hematocrit will be lower. You can look at their hemoglobin as well. You want to avoid NSAIDs. NSAIDs make platelets slippery, so you don't want to make crappy mortar and slippery platelets that will really increase their risk for bleeding. You want to administer the sub-Q every 12 hours. It's usually done in the abdomen, and you want to rotate sites. You don't want to rub the site after you give the medication because it will cause more bruising. It will have bruising already, but it will cause more. So you want them to report bruising, bleeding, a hematoma, which would be like a big bruise. A lot of times you can't see hematomas. They're like under the skin and they're like a bump. Black tarry stools, calf pain or swelling. We're worried about DVT. Now they shouldn't have that, but again, you want to keep an eye out for that. And then herbal supplements, again, should not be taken. Ginger, ginkgo, primrose. And the antidote for heparin is protamine. I'm not going to talk about it any more than to tell you that this is the antidote. So if you give too much heparin, your patient's bleeding out, they can't get this medication, protamine, and it will reverse the effects of heparin. Lovenox. Again, a low molecular weight heparin, and very easy for the body to use. It's a little safer than regular heparin. It doesn't require an APTT. The dose is based on the patient's weight, not on their lab value. And again, you're going to monitor side effects, same as heparin. Okay, warfarin. Warfarin's been around for a bajillion years. It is an old drug. The name that we know is Coumadin. It is an anticoagulant and it is a vitamin K inhibitor. Okay, so it antagonizes vitamin K, which stops this whole clotting cascade, and so decreases the production of all of these clotting factors, right? 7, 9, 10, and prothrombin. Side effects, you could have a hemorrhage. I don't know what PT or INR means, but that is how we monitor the drug, is through PT or INR. What we're looking for typically with the INR, which is the International Normalized Ratio, it is a calculation that's done on the PT, and the normal range on warfarin should be between 2 and 3. Okay, so the therapeutic effect though takes 3 to 5 days. So if it takes 3 to 5 days and you have someone who has, let's say, a DVT, right? You don't want to wait 3 to 5 days for them to begin to have the anticoagulant effects. So patients will take Lovenox for a few days because Lovenox works right away. And they'll also start taking Coumadin. And then they'll be watching their INR, and at some point they'll stop the Lovenox after a few days, and the patient will only be on warfarin. And again, I'll talk a little bit more about that. Okay, so the issue with warfarin is sometimes, you'll see somebody on warfarin and Lovenox, and you might be like, why are they on both? And this is the reason why, because warfarin's going to take 3 to 5 days to work. So while it's beginning to work, you need to cover the patient for anticoagulation with Lovenox. So make sure that you're clear about that. And if you see the patient on 2 anticoagulants, always good to ask why. And there might be a very good reason for that. But you as the nurse need to be the detective and go back into the chart and go look. And my guess is what you're going to find is that warfarin was started a few days earlier along with Lovenox. And the plan, and again, you can usually find the plan in the progress notes, is going to be to discontinue the warfarin when the INR gets to a therapeutic range. Or sorry, not the warfarin, you're going to discontinue the Lovenox. Because warfarin's a pill. Patients can go home on a pill. Not that patients can't go home on Lovenox, because they do. But you got to teach patient how to give themselves an injection, and that's kind of a pain in the butt. Okay, so nursing wise, you're going to monitor vital signs for hemorrhage. You're going to look at their CVC, their hematocrit. If perchance they get an overdose and they are very, very, they're bleeding and whatever, you may do vitamin K. But again, you want to be very careful because vitamin K actually can cause clotting. So yeah, it's this push-pull that we have with these drugs, right? One makes you less able to clot, but then it can cause too much bleeding. And then you have the other that will reverse that, but also in reversing it can cause clots that we don't want to happen. So this is a very specialized area of medicine. But if you do cardiac at all, this is going to be something that is part of your wheelhouse. Patients, if they are really bleeding from warfarin or, an overdose of warfarin, they may need fresh frozen plasma or whole blood because those components have clotting factors in them, whereas packed red blood cells, which we give most commonly, will not have those clotting factors. They will only have the red blood cells. You want to report signs of bleeding, so things like bruising, pain, swelling, actual oozing, blood in the urine, blood in the stool, whether it's overt or covert. You want to look at that. You want to avoid over-the-counter NSAIDs because this is just going to compound the problem. Again, you're going to have slippery platelets with these, and you're going to have crummy mortar with this, and together you're going to have a major hemorrhage if you're not careful. So teaching with the patient is very, very, very important. Things that they can and cannot have. They should not have aspirin while they're taking warfarin, right? Pregnancy is totally contraindicated. Category X means that this could cause death of the fetus. So it's something that has to be avoided at all costs. And then if the patient has a vitamin K deficiency, which often happens with alcoholism, you want to be careful. There's many precautions with warfarin, and if you work with patient population that takes it, you will get to know it very well. Lastly, we're going to look at alteplase or Activase. This is a thrombolytic. It can be used for acute MI, massive pulmonary emboli, so, multiple clots in the lungs, deep vein thrombosis, cerebrovascular accidents, that would be a stroke due to a clot, or an occluded IV. And when we say occluded IV, we most often mean not just a peripheral IV. We're usually talking about something that was a little more harrowing to put in, like a PICC line or an implanted port, or a central line that has been inserted directly into a large vessel. Those kinds of lines typically are long-term, and you hate to lose their effectiveness because of a clot. So if we can unclog them, that's a great thing. So this alteplase is a thrombolytic, meaning that it breaks apart clots. It's identical to an enzyme in human tissue plasminogen, so tissue plasminogen activator, TPA, and it converts plasminogen to plasmin, which dissolves fibrin clots. And it really is an amazing drug to use. I've used it many times on central lines. If you think about it, this is a vessel, but let's say this is a catheter, right? and all of a sudden you have this thrombus with all this junk in here, and now this beautiful catheter that this patient had implanted doesn't work. We can't draw blood out of it. We can't put infusions in it. If we can work a little of this Activase into the catheter and kind of around the clot or right up next to the clot and let it sit for a while, a lot of times it will dissolve the clot and move all of this through, and now we have a line that functions and works really well, which is so lovely. But it can also be used for clots that are in vessels too. Like I said, an MI, right, where there's a clot in one of the coronary arteries, or in the lungs where we have pulmonary emboli, in the legs. So these are, these can be given. If you're going to give it for MI, you need to give it within 12 hours of symptoms and within 3 hours for a cerebrovascular accident, which is a fancy term for stroke. The thing is, you have to know what kind of a stroke it is. Is it a stroke that's due to bleeding? Is it a stroke that's due to a clot? What's it due to? So the adverse effect of this, as you can imagine, is bleeding because it's too much of the intended effect. So the onset is 5 to 10 minutes. I mean, it really will work fast. When you infuse it into a catheter, you usually infuse it and let it sit for 30 minutes to an hour, and it works really well. It can be used for a STEMI. We talked about STEMI, which is an ST elevated MI, right? So the ST segment is elevated, and we know that this is a bad heart attack. It is a full thickness all the way through the wall heart attack. So you want to monitor for intracranial bleeding, depending on what you're using it for, right? PTT, PT, INR, bleeding time, hemoglobin hematocrit, platelet counts. So if you give the dose IV, you'll probably have 4 to 6 hours before the onset of symptoms of, bleeding. So you just want to be really careful, and you certainly wouldn't want to give it to a trauma patient, because a trauma patient, until they've been scanned and we know whether things are bleeding or not, we definitely don't want to use it. We also wouldn't want to use it in somebody who has a brain tumor, because a brain tumor tends to go in and erode vessels in the brain, and again, you would hate to cause a bleed in there. That is it, my friends. I hope that's helpful. And keep posted for my PT-INR video, and I will talk about this in class as well.